morning, everybody. I'm going to be picking up on some of the comments that Jonathan made about the importance of having the consumer at the centre of our work, and also will say something about possibly the things about working in the health system, both to the patients that we care for and for us. Maybe identifying some of the blind spots. The blind spot might be that sometimes we walk past people in our hospitals who are sitting like this, and we actually forget that those people may have been doing this the day before, the week before, but somehow some of our expectations, the things that we don't see anymore, are the things that we have to be mindful about. So what I'm going to do today or this morning in this presentation is really try to challenge some of the blind spots that we have about the people we care for, perhaps some of the blind spots that we have about what we think research is, and then think about some of the ways that we can actually have impact at the point of care. So yes, we're always searching after those incredible discoveries about the cure for cancer, as we heard this morning. But what we know about our health systems is that we actually harm a lot of people. So unintentionally harming people is also something that we have to research about, that we have to understand. And again, from some shocking figures from the United Kingdom, have identified that 4 people a day are dying in Britain's hospital wards thanks to either malnutrition or dehydration, with the elderly seen as most vulnerable. Now, hands up who thinks that's not a research problem. Hands up who thinks that could improve your financial bottom line. Hands up who thinks that would actually be better for patients if it didn't happen, and be better for staff if it didn't happen. Yeah. So you can begin to see that research is an interesting conundrum, because if I sort of put in an NHMRC discovery grant about reducing harm to patients and helping them to actually get fed properly, what do you think the group would say? Would they say, oh, well, that's just common sense? Would they say, well, it's those nurses, they should be feeding the people? Yes, they would, wouldn't they? So we all sort of click to the solution without actually reflecting on the fact that if this is a global problem in our health systems, then the way we're thinking about it is not fixing it. So we have to think differently. Hands up who thinks there are some patients in Flinders Medical Centre who are starving at this moment. And I'm not just talking about the ones that are going for surgery. So it could be that we don't have to look beyond our health system to think about how we can think differently. And to say, well, we've always done it this way is possibly not the answer either. So what I'm going to do in trying to convince you why translation matters is to give you 3 examples of research that I have been involved in that actually is tackling what some people would think are really common sense, ordinary problems, but they're so deeply embedded in our health systems that either we can't see them or we sort of explain them away. So the first one is a project that I was involved with in a couple of years ago, and it was prevention and reduction of weight loss in the acute care setting. So the evidence that we were introducing into a hospital health system was a 3-pronged approach, which was the intervention. And this was developed from sort of evidence-based practice. So evidence shows that if you screen for malnutrition using a simple screening tool, that reduces the possibility of malnutrition in those sort of people who are at risk of it. If you have additional nutritional supplements easily accessible in the ward situation, that will help. And also if you provide assistance with feeding, that was the intervention. We decided we would go for all inpatient wards. So this hospital had 24 wards, and we engaged a wide range of stakeholders, particularly nurses and dietitians, but also food service staff and clinical, at both clinical and managerial levels. We used a sort of a stepped wedge design, which meant that each ward became its own sort of control. And we set this study off in 4 phases. So the first 6 with 2 facilitators, a dietitian and a nurse, introduced the intervention. And over that period of 18 months, we sort of checked what was happening. We used local audit and feedback in each of the wards, and we also, the outcome measure that we used was weight loss. And some of the stories are quite interesting, because one of the biggest problems that we had whenever we tried to introduce this intervention was, guess what? We couldn't generate a reliable way of weighing patients, because every ward had either a broken weighing machine, or they couldn't find one, or people, there was a lot of controversy over whether you should weigh patients, and indeed, if you did, who should do it and on what day you should do it. So interestingly, in just trying to generate a sort of a study that tried to identify weight loss, we came across this significant challenge across the hospital. Now, that raises another interesting question, because if the actual weighing of patients is so unreliable, then why should we spend time doing it? And how much time and effort is used to weigh inaccurately patients? So that also generated a lot of very interesting questions. What we found was that we were able to identify that this particular intervention did reduce weight loss in the most vulnerable patients, but there was no significant difference in those patients who were, at risk, but we couldn't find it over the 7 days that we were tracking them. But what we did find was that there was interesting variation across the different groups. So the groups were the groups of 6 wards that sort of went off in the journey at different times. But you can see that, again, it goes back to Jonathan's question about the variation. Within this system, there was significant variation, both at the start of the intervention and then at the end of the intervention, and then at the final 6 months testing. So we weren't able to explain why there was variation within the system, both in the must assessment and also in the nutritional supplements given. Again, interestingly, we found that one of the biggest problems in order to provide nutritional supplements in the wards was that there was a lot of controversy over where you should keep the nutritional supplements, because you can't really put them in the drug cupboard. You can't put them in the cupboards in the kitchens, because allegedly people would steal them. And there was also an issue about the actual stores. It took 3 weeks for a nurse leader between the time that they identified the need for a nutritional supplement to then 3 weeks turnaround to get that supplement into the ward. So then you begin to understand the sort of hoarding behaviour of people at ward level, because if they reckon that it's going to take 3 weeks to get something they need, they'll sort of do the anticipatory, well, I better just sort of order it because you never know when it's going to come. So again, this is sort of understanding the cultures that we work in, and also understanding that even though the evidence around must nutritional supplements and red trays as a way of identifying patients who need help to eat, whilst each of those three things in themselves is relatively unremarkable, what was truly remarkable was actually to try and get it into practice. So these are the things that we need to reflect on, because we can, and also the reason why we need to do the research, because I'm quite sure when we fed back to these different wards, they weren't aware that they had such variation across the hospital. And it's only when people get feedback on their performance that they actually can do something about altering why they're doing things. Okay, so making sure that people eat in hospitals is not easy. Another interesting piece of research undertaken by two colleagues from the University of San Francisco, Diane Baker and Barbara Quinn, they actually discovered that hospital-acquired pneumonia prevention can be reduced by making sure that patients, before they go to surgery, have their teeth washed. Okay, so again, it's not rocket science. Just think of someone who's going to theatre and nobody's checked that they've got a clean mouth. And guess what's happened? You've got the intubation, all the stuff happening. They did a survey across a number of veteran affairs hospitals across the US, and they were able to demonstrate that with the introduction of a very simple intervention as part of the surgical protocol, which was make sure that patients' mouths are clean, they were able to reduce the incidence of non-ventilator hospital-acquired infection. So, a little test. Hands up. Who thinks that as part of the surgical protocol in Flinders Medical Centre, that as well as doing prophylactic antibiotic therapy, you check that the patient's mouth is clean? No hands. So that means that we could actually have a little research project. And I'm so sorry that our Flinders seed funder person is out of the room, because I think this is a wonderful piece of work. Because how long do you think it would take? How many surgical wards are there in FMC? 10? 8? 2? 6? Okay, how long do you think it would take to get everyone tuned in to the fact that they would check a patient's mouth to make sure it was clean before they went to theatre? 1 month? 6 months? 12 months? 2 years? You don't know? I don't know either, but you see, it actually don't think it's straightforward, because again, if people would use logic and think, okay, I've read this, it's really good, this thing matters, and indeed, I may convince you that it's important to make sure that patients' mouths are clean, but how are you going to get that spread around? How are you going to change people's patterns, behaviours, routines? Because the first thing the team will say, I'm too busy, I can't possibly do that, or it's not my job. So how do you change it? And again, going back to what Jonathan said, patients, consumers, the public would almost be, that they would be thinking, why don't you check? You know, they would be a bit surprised that we're not doing it. But in Central Adelaide Local Health Network, we actually took the evidence around good oral hygiene, and we did a prevalence audit, and these were the medical, surgical, renal, mental health, prison health, critical care and cancer. And this, all I can say is there's lots of room for improvement. So this was a retrospective chart audit looking at how each of these areas was tracking against the evidence-based oral hygiene criteria. Now, again, think of critical care. This is the orange one here. We can see that if we look at criterion 4, well, that's probably understandable, but criterion 2, so you begin to get a sense of how you can look at the routine behaviour and the activity. The other thing we can say about this data is that Prison Health obviously knew we were coming. So sometimes if you want to cheat, don't cheat too effectively. And then the third example I will give you, and I'll share this with you because I know that several of you may have met Alison Mudge recently when she was over at FMC. I have worked with Alison for this last 5 years, and again, you would know that her sort of research is trying to improve or reduce the incidence of delirium in older people in hospital by introducing better nutrition, better mobility, and better social interaction. Again, not rocket science, but it does require a huge amount of effort and coordination to get these 3 activities embedded in an acute hospital ward. And I think, again, that reflects some of our blind spots because we know that by the nature of the patients who are coming through our acute wards, we have to be mindful of both the risk that they're under and the way that we need to change the routines that we have to accommodate their actual needs. So what have we learnt in this example of 3 activities? Well, basically, from my own reflections on the work that I do, the first challenge is that we have to change the way that we look at things. And that's very, very difficult because, we sort of get patterned in our assumptions and our views of the world. What I have done over this last 25 years or so is trying to understand what the complexity, what are the factors, what are the issues that are really, really stopping us from doing the things that we know are right, from doing the things that we know evidence is telling us to do. And rather than beating ourselves up about it, actually saying, you know what, this is complex. The theoretical framework that we have worked on and that people like Alison Mudge has working on is called the I-PARIS framework. And it's called, PARIS stands for Promoting Action in Research, Implementation and Health Services. And so basically what it really says is that successful implementation equals the way that you facilitate the innovation or evidence that you're putting into the system, the recipients, so the people and the teams that are receiving the evidence need to be facilitated, and the context into which you are putting the evidence needs to be understood. So if you want to learn something more about translation, then if you can remember this formula, that is a good start. But the issue is that that little formula reflects a much deeper and more complex world. So the next time that you start to have a conversation with your colleagues about why it's difficult to get things into practice, then it's difficult because there's multiple variables and factors that need to be considered. And the really wonderful thing about the SA Translation Centre is that this is how we can open the Pandora's box, so that people who are at risk of malnutrition, people who need their mouths cleaned, and people who need to avoid delirium, they are dependent on us to actually have a sense of how we do it. So what we will do, well, we're going to, and certainly in my role as Vice President of Nursing and Health Sciences, really looking forward to being able to work collaboratively with you to build that translational capacity. And we have a program running in November that will help us go through that. And that is to generate impact that we can see and feel, and that we will be doing that with our local, national and international collaborators. Thank you.